My name is Dr. Wisdom. You're welcome to another episode of Headaches and Headaches of neuro-ophthalmic origin. So today is the part 3 of several parts. We have begun to teach on part 1, part 2, and today is part 3. I hope it's going to be exciting. I hope it's going to be fun-filled, and I hope you will be able to learn one or two from this brief session of mine. Please do well to subscribe, like, comment, and share this channel. As do so, God bless you in Jesus' name. So quickly, we have been looking at headaches. We have been trying to trace the pathway of headache. Most times patients come to the clinic and most of their complaints are headache, and it is essential, like an expedient, that every practitioner understands this concept and knows how to go about it. So in our last class, we are talking about important clues to note in the cause of headache. We talked about the frequency, we talked about the location, duration of onset, that the location of the headache, it plays an important role in telling you the type of headache we are dealing with. We also talked about the intensity of pain, how intense the pain is a pointer and a clue on what we are dealing with. We also looked at the usual cause, the triggering factors, and then the family history. So this was all we're able to look out for in our last class. That was 2 weeks ago. So today we want to look at another important aspect of headache, and then we want to make progress. Today we are looking at migraine headache. We want to understand what it is, we want to know what it is, we want to know what causes it, and want to know how to be able to identify migraine headache. And finally, we want to also look at the treatment plan in migraine headache. So it's going to be all this and a whole lot more. Sit tight, grab a cup of coffee or a cup of tea or whatever it is you are drinking, and then enjoy the show. So quickly, what is migraine? We want to understand what migraine is all about. So migraine is a type of headache that is the most common in the clinic. Of all the types of headache we are going to be looking at, migraine is the most common, and it is most times the most, how will I put it now, not just the most common, but it is a tricky one that needs special attention to be able to diagnose and then able to treat effectively. So quickly, the International Headache Society has given us a guideline or a criteria for diagnosing migraine, because there is migraine with aura and then there is migraine without aura. So the International Headache Society, they've come together, this association of wise men, they've come together and then they've put up a criteria to be able to classify migraine into aura and without aura. So let me just give you a rundown before we begin the teaching for today. They have classified that headache, the classification of migraine without aura is that headaches lasting for 4 to 72 hours. Lasting for 4 to 72 hours, whether it was treated successfully or not, is one of the criteria for classifying headache without migraine. The second classification is headache that has any two of the following characteristics. One is unilateral location, the two is pulsating quality, the three is moderate or severe intensity, the fourth is aggravation by walking stairs or similar routine physical activity. So any two from these four I have listed is one of the criteria for classifying migraine without aura. Are we together? And again, another classification is during headaches, at least one of the following should happen: nausea or vomiting, photophobia or phonophobia. So one of these should happen for it to be called a migraine without aura. Another classification is not attributed to any disorder. In other words, there is no underlying disorder we are looking at. So this is the classification of migraine without headache. And also, there is a classification or a criteria for classification of headache with aura, and this is the table for it. aura consisting of at least one of the following, but no motor weakness. The first is fully reversible visual symptoms, including positive features, e.g. flickering of lights, spots or line, and or negative features, that is loss of vision. I'm going to explain all this when I begin to teach. And again, secondly is fully reversible sensory symptoms, including positive features, that is pains and needles, and or negative features, that is numbness. And the third is fully reversible dysphasic speech disturbance. The second table for classification is at least two of the following. The first is homonymous visual symptoms and or unilateral sensory symptoms. The second is at least one oral symptoms developing gradually over more than 25 minutes and or different oral symptoms occurring in succession over more than or equal to 5 minutes, and then each symptom lasts for about more than or equal to 5 minutes and less than or equal to 60 minutes. Also, headaches fulfilling the criteria B and criteria D for migraine without aura begins during the aura or follows aura within 60 minutes. So, and again, it should not be associated to another disorder. So this is a quick one on how the International Headache Society has graded or classified headache into aura and headache without aura. But today, let me begin to explain what I just read to you so that it will begin to make more sense and you can be able to appreciate migraine headache. So migraine is a disease that causes headache the most. It is the disease that causes headache the most, migraine headache, and also it is more prominent in women. Women are more the major sufferers of migraine, and it is, in fact, from research, it shows that it happens more than twice in women than in men. So most times you see issues of migraine, women usually suffer it most because, like I said in the previous classes, that menstrual cramps, menstruation is one of the triggers to migraine. So it is usually found more in women than in men. And also it is highest among 30 to 50 year olds. You see, those who are within the range of 30 to 50 are more likely to suffer from migraine. So sometimes age is dependent of how often you suffer from migraine, and also it is more in the whites than in the blacks. So the whites have more tendencies to suffer from migraine, and then patients with migraine have a higher risk of having stroke, especially those with aura. So patients who have a migraine with aura, whereby it affects their visual symptoms, they have a higher risk of eventually going into stroke. So this is why every time you have migraine headache, every time you experience this kind of headaches, it is good and important to rush down to the clinic or to the hospital for proper evaluation and then proper treatment, because if left untreated, the more it happens, the more it progresses, you are likely, you have a higher tendency of suffering from stroke. So this is not to scare you, but this is to make you become more responsible with your health. So, and in migraine, like I said earlier, aura may be present or aura may be absent. So what do we mean by this aura per se? So aura is a set of neurological symptoms. They are usually visual. It's a set of neurological symptoms which are usually visual, sensory or speech related that accompanies migraine. So aura is sensory related, it is auditory related or speech related, in the sense that your vision is distorted, your hearing is distorted, or your ability to speak is distorted. This is what we mean by aura, and then it is usually accompanied in migraine. So aura may be present in migraine, it can be absent. And again, I want you to note that migraine is usually unilateral, that it is one-sided. It can be this way, it can be one side, but there are rare occasions where it is bilateral, but it can also be bilateral anyway. But most times people who suffer it, they tend to say that it is unilateral, and then it spreads gradually from one point to another. It spreads gradually, and also it is frontotemporal. So that means it is here, the front to this place, or from the front here to this place, and pulsating in nature, in the sense that it's as if it is trying to blow out a closed door. So it is pulsating on the door. This is what we mean by pulsating in nature. And again, activity increases or exacerbates the condition. People who have migraine have reported that if, assuming they're in a workplace, and then they came down with migraine, it seems as though the more they were involved in activity, the migraine increased. So activities such as sexual performance can increase the intensity and the efficacy of migraine. So this is why we advise that every time you have migraine headache, please take a rest and make sure you are relaxed so that it takes its natural course and then it goes away. But if you are going to experience migraine and then you are also working at the same time, you are just aggravating the condition. Also, sensory stimuli are trigger. So sensory stimuli are trigger to migraine. What do we mean by this? Sensory stimuli in the sense that too bright lights can trigger migraine, too loud noise can trigger migraine, certain smells can trigger migraine. For some people, if they're exposed to too bright light, after a while it leads to migraine. So that is a trigger. For some people, when they are in a very loud environment, like people who club a lot, they usually have symptoms of migraine because they're exposed to too loud sound coming into their eardrums, and then it triggers migraine. And some people, again, certain smells like certain chemicals, certain plants can induce migraine headache. So stimuli are triggers to migraine. And again, due to the triggers from these sensory stimuli, patients usually are forced to find refuge in solitary places. Like if it is triggered by light, you find out that such patients, they want to go to a dark room to stay. If it is triggered by sound, such patients want to go to a quiet place. So it gives them a sense of solace. It gives them a sense of tranquility because they are now removed from what is triggering it. So patients who usually have migraine want to, you see that they want to stay in excluded places, they want to stay in quiet places, they want to stay in dark places, and they want to stay in ventilated places where there are no unusual smells. Are we together? And again, it can be accompanied with autonomic phenomenon. What we mean by autonomic phenomena are there are conditions which you cannot control, e.g. vomiting. You cannot just say you want to vomit. So they are called autonomic phenomena, so whereby you can't control how and when they happen. So migraine is usually accompanied with autonomic phenomena such as vomiting. So you find out that in a patient who has migraine, they tell you that they were vomiting severally. So it's also an indicator to lead you that what the kind of headache they are having is a migraine headache. Also, nausea is one of the autonomic symptoms we see in migraine. So triggers can be easily spotted, unlike other types of headache where you are not sure what is triggering it. But for migraine headache, the patients can easily trigger what spotted it, can easily spot what triggered it. So for instance, they can tell you that, oh, it happened immediately I went to the market. So you know that activity induced it. So they can tell you, oh, it happened after I had marathon sex, or it happened after I was exposed to too bright light for some time, or it happened after I was exposed to very loud noise for a certain period of time. So the triggers can be easily spotted, and that is the good thing about migraine. But yet, it is still a dilemma in the clinic. But with these few points I've been able to bring out over time, you'll be able to see that the triggers are not far from within you. The triggers are not far from within you, and you can easily spot them. So pain usually lasts for about 4 to 72 hours. The pain of migraine usually lasts for about 4 to 72 hours. That is about 4 hours to days. So it's not an easy one per se, and it is a terrible pain. So you find out that the patients are in pain for 4, 3, 5, 6, even up to days. So this is one of the issues seen in a migraine, and it's usually relieved the following day after a prolonged sleep, because during sleeping you are in a state of inactivity. So inactivity helps to quiet down the progression of migraine. So you find out that most patients, once they go to sleep and then they wake up, they tend to have relief. They tend to have relief of their migraine headache. So attacks of more than a day are usually uncommon in migraine. So you see attacks of today, tomorrow, they are usually uncommon. They are possible, but they are rare in migraine. And episodic attacks may develop into chronic migraine, which is marked with 15 or more headaches in a month. So what I'm trying to say is that if the migraine keeps happening and it keeps happening, and maybe the patient is not treating it, or he's just taking paracetamol, or he's just taking self-medication, it can now progress into what we call chronic migraine. And in chronic migraine, we are having about 15 or more migraines in a month, and which means from statistics, it is as though that every 2 days you are down with migraine. And this disrupts your social life, disrupt your economic life, disrupt everything about you. So it's not what we want to you want to wish for an enemy. So that is why it's important that every time you have migraine, you make sure your health practitioner is aware, and then effective measures are taken, because if it keeps happening like that, it can proceed to what we call chronic migraine, characterized by 15 or more headaches in a month. And migraine with aura was previously known as ophthalmic or classic migraine. So that was the previous name we call migraine with aura. And then currently, aura symptoms usually occur in about 25% of patients. And I've said earlier that aura are neurological symptoms, usually visual, sensory, or speech related. So there are symptoms affecting your ability to speak. So you see someone having a slurred speech, affecting your vision. You are seeing what is not there, or you are seeing what is there already. So something affecting your speech, or it could be smell. It could be smell related. So that is it for oral symptoms, which occurs in about 25% of patients. So aura, there are two classifications of aura, of migraine with aura. There is the migraine, there is the positive, and then the negative aura. There is the positive aura and negative aura. So in positive aura, you are seeing something that is not really there. So in positive aura, the patient is seeing an imaginary thing. It's just like a mirage while driving, and then you see, it seems as though there is water in front, but there is no water. So that is what positive aura means. The patient is seeing something that is not really there. So for instance, this patient is seeing bright flashes of light during the migraine, or the patient is having blurry vision. It seems as though the whole world has gone blurry, or the patient is having scintillations. So it's seen as though a part of a segment has been cut out, or the patient is experiencing what we call heat waves. So you find out that the patient is telling that it seems as though smoke is rising out from things. So in aura with migraine, the patient is seeing what is not there. That is for the positive aura. The patient is seeing what is not there, and that is normal. So he comes down with the symptoms of seeing bright flashes of light, blurry vision, scintillation, heat waves, and so on and so forth. And then the negative, in the negative aura, the patient is seeing parts that are missing. So he's actually seeing something, but it's not complete. That is what negative aura is all about. So in positive aura, he is seeing what is not there. So what a normal patient is seeing is, he is seeing a wall that is white. But in a positive aura, the patient is seeing the wall, but then he's seeing other things that are not in the wall. But in negative aura, the patient is seeing parts that are missing. So he's seeing a wall, and it's as if some part of the wall is chopped off. So one of the symptoms we can see is that there's a transient vision loss. So the patient can't see for some time, and then you see area of blind spot. It's as though the whole place is covered in darkness. And again, there are symptoms of tunnel vision, which is seen in advanced glaucoma. So you see a case of tunnel vision, whereby the patient is like, oh, I'm having serious headache, but then I can't see things happening peripherally. So he just seeing straight ahead, but he can't see things happening in his or her periphery, and also a loss in color vision. So you find out that brown things, colors appear faded, or they appear in black and white. So this is what we call the negative aura. So in the positive aura, the patient is seeing a thing, but then what he's seeing is not really there. But in negative aura, he is seeing something that has been cut out, that is there but it is not complete, characterized by tunnel vision, blind spots, loss of color vision. So migraine without aura was previously known as simple migraine or hemicrania. So when I'm done with this class, with the whole session, the series is going to be a long series because headache and associated symptoms is a large and broad concept. I will then be publishing the slides which I have prepared, and then you'll be able to see and appreciate the pictures of these things I'm talking about, so that it will give you a proper mental view of what I'm talking about. So in my slide here, I have a picture of scintillating scotoma, I have the picture of tunnel vision seen in migraine, and then so all this will be in the slide when we are done with the series. Or probably after this mini series, I will then do a complete video, maybe on Zoom or Google Meet, where it will just be the whole video in one, so that it can also give us the opportunity to ask questions, and also give us the opportunity to see the pictures and then appreciate the lecture in a better sense. So there are unusual forms of migraine. I'm just going to introduce them today, and in our next class, I'll be giving an in-depth analysis to each and every one of them. So I'm just going to introduce them this evening, and then in our next class, I'll pick out one, and then we'll discuss it and then break it down, so that we'll be able to understand these things. I'm taking the class bit by bit, so that it won't be so much on us, and then we can be able to digest and understand what I'm teaching. So there are several kinds of unusual forms of migraine, in a sense that they are not common, they are not as common as the aura and without aura migraine, but they are still there, and it's important that we look at them, it's important that we discuss them, and it's important that we understand the pathophysiology of them. So the first is basilar artery migraine, with symptoms such as diplopia, vertigo, tinnitus, paresthesia in the face, ataxia, all those. So there is another form of basilar artery migraine. Another form of an unusual kind of migraine is ophthalmoplegic migraine. Ophthalmoplegic migraine is like the word ophthalmoplegia, which means paralysis of a muscle. It is usually accompanied with ptosis and diplopia. So when you see ptosis and diplopia, likely there is an induced ptosis with double vision. Likely what we are looking at is ophthalmoplegic migraine. And then there is also retinal migraine. In retinal migraine, it is just in one eye and not in the other eye. We are going to look at all these. Also, there is what we call complicated migraine. There is also benign episodic migraine. There's also hemiplegic migraine, migraneous vertigo, and then migraine in women. So you see women who are in pregnancy or who are menstruating, there's a special kind of migraine they have, and we're going to look at all these in the next class. So I want to thank you for joining us. It's a brief class, so let me do a quick summary of what I have taught today. I have taught you on that migraine headache is more in women than in men, and then it's the most common type of headache, and it's more in the whites than in the blacks, and patients with migraine have a higher risk of running to stroke. And then I've also said that it is highest among 30 to 50 year old, and I've also differentiated aura from non-aura, and I said that aura are neurological symptoms which can be visual, sensory, or speech related. And then I have said that migraine, the triggers of migraine can be easily spotted, and activity aggravates the progression of migraine. And then I also said that sensory stimuli are the common triggers of migraine, and also pain lasts for about 4 to 72 hours, and they are relieved after sleeping. And I've also said that the episodic attacks can lead to chronic attacks, which is characterized by 15 or more headaches in a month. And I've also said that aura can also occur in 25% of patients. And I've also taught on the positive aura and negative aura. In the positive, you are seeing what is not there. In the negative, you are seeing it, but a part of it is cut out. And then all this is just what I've discussed. So in our next class, we are going to be looking at the uncommon forms of migraine, and then we are going to do an in-depth analysis. Thank you so much for joining us. My name is Dr. Wisdom. So do well to subscribe, do well to like, do well to comment, and do well to drop your questions on the inbox. I'll find out time to reply all of them, and I'll make sure we are going to make progress. So I hope to see you in our class next week, same time, same venue, same station. Remain blessed, keep making progress, and keep impacting your world. God bless you.